Borderline personality disorder, BPD, represents one of the most complex and frequently misunderstood mental health conditions in clinical practice today. This serious psychiatric disorder affects approximately 1.6% of the general population, with significantly higher prevalence rates in clinical settings. BPD is characterized by a pervasive pattern of instability in interpersonal relationships, self-image, and emotions, accompanied by marked impulsivity that begins by early adulthood and causes significant distress across multiple contexts of an individual's life. The emotional landscape of someone living with BPD is often described as similar to having third-degree emotional burns, where even minor stimuli can trigger intense reactions. Individuals with this condition experience emotions with exceptional intensity, particularly negative emotions such as anger, shame, and fear. These emotional storms can arise suddenly, overwhelm the individual completely, and take considerably longer to return to baseline compared to those without the disorder. This emotional dysregulation represents one of the core features of BPD and significantly impacts daily functioning. Interpersonal relationships for those with BPD often follow tumultuous patterns characterized by alternating between extremes of idealization and devaluation. An individual may initially perceive a new friend or romantic partner as perfect and uniquely understanding, only to dramatically shift to viewing them as malicious or uncaring after a perceived slight or disappointment. This pattern, sometimes called splitting, reflects the difficulty people with BPD have in integrating positive and negative qualities into a coherent whole. Underlying these relationship patterns is an intense fear of abandonment that drives frantic efforts to avoid real or imagined rejection. The self-image of someone with BPD typically lacks stability and coherence. Many describe feeling fundamentally flawed or empty inside, with a weak sense of who they truly are. Their values, goals, career aspirations, sexual identity, and even sense of their own personality may shift dramatically over short periods. This identity disturbance contributes significantly to the distress experienced by those with the disorder and can lead to chameleon-like adaptations where the individual changes their presentation based on their social context. Perhaps the most concerning aspect of BPD involves the impulsive behaviors that often accompany the condition. Self-harm behaviors, such as cutting or burning, occur in approximately 75% of individuals with BPD and serve multiple functions, including emotional regulation, self-punishment, or as a means to feel something when experiencing emotional numbness. Suicidal behaviors are alarmingly common, with approximately 70% of people with BPD attempting suicide at least once during their lifetime, and the completed suicide rate estimated at 8–10%, significantly higher than the general population. The development of BPD involves a complex interplay of biological, psychological, and social factors. Research suggests a heritable component, with first-degree relatives of those with BPD 5 times more likely to develop the condition. Neurobiological studies have identified alterations in brain circuits responsible for emotional regulation, impulse control, and social cognition, particularly involving the amygdala, hippocampus, and prefrontal cortex. Childhood trauma, especially emotional neglect or abuse, sexual abuse, and early separation from caregivers, represents a significant risk factor, though not all individuals with BPD report traumatic histories. The biosocial theory proposed by Marcia Linehan suggests that BPD develops when emotionally sensitive individuals grow up in invalidating environments. In this model, biological predispositions toward emotional sensitivity interact with environments that punish, trivialize, or respond erratically to emotional expression, resulting in emotional dysregulation and the development of maladaptive coping strategies. This theory underlies dialectical behavior therapy, DBT, one of the most effective treatments for BPD. Diagnosis of BPD requires careful clinical assessment, as many symptoms overlap with other psychiatric conditions such as bipolar disorder, post-traumatic stress disorder, and other personality disorders. According to diagnostic criteria, an individual must display a pervasive pattern of instability in relationships, self-image, and affect, along with marked impulsivity, beginning by early adulthood. Specific symptoms include frantic efforts to avoid abandonment, unstable relationships, identity disturbance, impulsivity in potentially self-damaging areas, recurrent suicidal behavior or self-harm, affective instability, chronic feelings of emptiness, inappropriate anger, and transient paranoid ideation or dissociative symptoms. The historical stigma surrounding BPD has unfortunately affected both clinical attitudes and treatment approaches. For decades, many clinicians considered the condition largely untreatable or avoided working with these patients due to the challenges they present. Fortunately, this perspective has shifted dramatically with the development of effective psychotherapeutic approaches specifically designed for BPD. The prognosis is now considered much more optimistic than previously thought, with longitudinal studies showing significant improvement over time for many individuals. Treatment for BPD has evolved substantially in recent decades, with several evidence-based approaches demonstrating effectiveness. Dialectical Behavior Therapy, DBT, developed specifically for treating BPD, combines cognitive behavioral techniques with mindfulness practices derived from Eastern philosophical traditions. DBT focuses on 4 key skill areas: mindfulness, distress tolerance, emotion regulation, and interpersonal effectiveness. The therapy typically includes individual sessions, skills training groups, phone coaching, and therapist consultation teams to provide comprehensive support. Mentalization-Based Treatment, MBT, represents another effective approach, focusing on enhancing the individual's ability to understand mental states in themselves and others. Schema-focused therapy addresses early maladaptive schemas and coping styles that underlie BPD symptoms. Transference-focused psychotherapy utilizes the therapeutic relationship to explore and modify problematic internal representations of self and others. Each of these approaches has demonstrated efficacy in randomized controlled trials, providing multiple options for treatment. Pharmacotherapy plays a supportive rather than primary role in BPD treatment. While no medications specifically treat the core pathology of BPD, certain medications may help manage specific symptoms. Selective serotonin reuptake inhibitors, SSRIs, may reduce emotional intensity and impulsivity. Mood stabilizers and atypical antipsychotics sometimes help with affective instability and cognitive perceptual symptoms. However, medication should generally complement rather than replace appropriate psychotherapy. The recovery journey for someone with BPD often proves challenging but increasingly achievable with appropriate treatment. Many individuals show substantial improvement over time, particularly when they remain engaged in therapeutic processes and develop effective coping strategies. Longitudinal studies indicate that approximately 85% of people with BPD achieve remission from their symptoms within 10 years of diagnosis, though some functional impairments may persist. Recovery typically involves developing emotional regulation skills, building a stable sense of identity, establishing healthy relationships, and creating a life worth living. Family members of individuals with BPD often experience significant distress and may benefit from support and education. Programs like Family Connections provide valuable information about the disorder and teach skills for effectively responding to their loved one's behaviors while maintaining appropriate boundaries. Understanding the nature of BPD can help family members respond more effectively during crises and support their loved one's recovery process without enabling destructive behaviors. Recent research has expanded our understanding of BPD and continues to refine treatment approaches. Neuroimaging studies have identified specific brain alterations associated with the disorder, potentially leading to novel treatment targets. Early intervention programs are being developed to identify and treat adolescents showing prodromal signs of the disorder. Dimensional models of personality pathology, as reflected in alternative diagnostic frameworks, may better capture the heterogeneity observed in clinical presentations and inform more personalized treatment approaches. In conclusion, borderline personality disorder represents a serious but treatable mental health condition characterized by emotional dysregulation, unstable relationships, identity disturbance, and impulsive behaviors. With appropriate intervention and support, many individuals with BPD can achieve significant symptom reduction and build fulfilling lives. Continued research, education, and destigmatization efforts remain essential to improving outcomes for those affected by this challenging but increasingly understood condition.